Good morning, everyone, and welcome to this Global Approach breakout session, where we're going to be discussing the UK's current approach to global health. I'm not going to speak for very long because we've got four fantastic panellists who are going to bring perspectives from different parts of the UK and further afield from Ghana on the ways in which the UK is connecting on global health at the moment. This, of course, all comes on the background of, it's an understatement, isn't it, to say that it's been a difficult year or a difficult 2 years. And we've had so much discussion through this conference and some very moving testimonies of all the things that have been happening, both in terms of the acute pressures of COVID and the effects of those on health and care workers, but also the health partnerships who have responded to that in many positive ways, and the solidarity that has been shown between healthcare workers across the world through these partnerships and through much less formal connections. At the same time as that, of course, there have been huge changes in the UK, which is refreshing the way in which it spends development assistance, official development assistance. So we all know that that has been cut significantly and that has had a major effect on health partnerships, particularly through the cuts affecting the grants that Theta would have administered and all the work that had gone into preparing those by health partnerships around the country and around the world. We know that the UK FCDO, the Foreign, Commonwealth and Development Office, is about to publish a new international development strategy. It has consulted on that and we expect to see it by the end of the year. We know that Britain is also refreshing its global health strategy, which is cross-departmental. Some of the speakers will bring some perspectives on that and some will be more focused on particular areas of work, but they will all be highlighting the ways in which Britain is connecting and in some cases responding to how that looks from partner countries. We will have plenty of time for questions at the end, so please, as we go along, do post your questions in the question box. I will come to questions at the very end of all the speakers, but in case you forget, if there's something for a particular person, please put it in the question box and address it to that person. Without further ado, I'm going to introduce our first speaker. Our first speaker is Gail Marzetti. She is head of the International Workforce Team at the UK's Department of Health and Social Care. She has a long background in international development and global health and will bring us her perspectives on this topic. Thank you, Gail.
Thanks very much, Kit, and good morning or good afternoon, everyone. I'm delighted to be here at this conference, and thank you very much to Theta for inviting me to speak here about health partnerships, the NHS, and the global work that we're doing in the International Workforce Team of the Department of Health and Social Care for the UK. So first, I'd like to say that I've been able to join quite a lot of sessions of this conference, starting from Thursday last week. And I've really been struck by the stories of healthcare from across an unequal world, but also the impact of inequality and discrimination on both health workers and patients within the NHS. Some of this we knew already, but COVID has really stripped bare the inequalities for the UK, but also the inequalities in the workforce and the inequalities of experience of patients from different backgrounds. So I think it's been really interesting to me to hear how people have experienced that as workers in the NHS during this conference. Because COVID was able to show some of it, particularly the disproportionate effect of COVID on our BAME workforce, we have been able to do some work to start improving things. For example, trying to improve cultural and pastoral care, doing more leadership training for the international workforce and giving them more support. But I think there's much more that we need to focus on, and I think that's really been coming out. So I hear that message. And I was also really struck by Dr. Theta's message at the opening of the conference, where he said, a common threat needs a united and compassionate approach. So I've heard the urgency to get practical, and I'd just like to talk about some of the work that the Department of Health and Social Care is doing to try and make a compassionate and sustainable difference, both to our health workforce, but for the global health workforce. So my team is responsible for setting the ethical framework for recruiting international staff, and we're aiming to make a sustainable and positive change towards equity and use that opportunity of an incentive of an international job to also increase the number of global healthcare workers more generally across the world, making recruitment a win for the migrant worker who has a right to migrate under the Convention for the Migrant Worker, but who comes to the UK as a valued, talented worker with professional aspirations that we would like to develop and give them a career and an experience where they feel valued and respected. And I've heard the concerns and experiences where this has not happened. A win for the NHS through having a very talented and diverse workforce, which it has always had since 1948. And a win for the health system of the source country by putting governance in place to ensure that international migration into the UK is managed in the best interest of the health system of the supply country, not just the economy, where obviously remittances and unemployment are affected, but actually how can we do this in a way that benefits the health system. So moving to the next slide, I'd like to just give very briefly, some examples of how we're doing this. So we have recently signed in July this year an MOU with Kenya to recruit unemployed Kenyan nurses. It's been really striking for me since I've been in this job how many unemployed healthcare workers there are across the world. And there's nothing ethical in people either paying for their own training or going through training to join a profession and then finding that due to certain circumstances, they're unable to work. So getting those unemployed nurses into work, both in their own country and internationally, is something that we're really interested to do through NHS partnerships to train and upskill and then bring people back into the workforce. So in Ghana, we're working with Theta and the NHS partnership model to support the training of workers and to support health, human resource management, to try and find, to get people back into work and to increase the number and the quality of health workers. But we're also, as part of that work, where we've got some overseas development assistance finances, we're partnering with WHO, for example, on how to use incentives to finance nurses and salary top-ups, for example, to work in remote and rural locations that are underserved in Ghana. So one of the models that we could try is using the recruitment fee to actually get more nurses into remote and underserved areas of Ghana, whilst others are coming into the workforce in the UK, and particularly again focusing on unemployed nurses, which WHO has estimated for Ghana to be about 40,000, and the Ghana government estimates as many more. Also in Ghana, we're working with the Christian Health Association of Ghana to train refugees in refugee camps, displaced people's camps on the borders of Ghana to become healthcare workers as a way out of their displaced status. And a further advantage of that, the evidence shows from other places, is that if there's an opportunity of a professional work for refugees, that there will be more investment in secondary education for the children. So this is a chance to escape from displaced camps and get professional work, which can be used either in the camp or back if they're able to return home, or anywhere else in the world. No one has to come to Britain. This isn't bonded labour. It's just giving skills and qualifications that are internationally recognised and can be used anywhere. In Somaliland and in Uganda, we're also working with Theta taking some of those partnerships which Kit referred to at the beginning of this talk, which FCDO have not been able to finance, but the ones that are about workforce and about training the workforce and about workforce management, and funding those to go ahead, partnering with local institutions and NHS institutions on a wide variety of different areas to strengthen, for example, courses, update curriculum, give continuous professional development, refreshing training, strengthening regulations. There's a whole range of work that we've been able to fund in this financial year, and that I'm very hopeful and would very much like to fund in the future, as in the next spending review of the UK, next 3 years. And finally, moving to the next slide, I would like to talk a little bit about our work that we're doing to bring refugees into the workforce. So I've already mentioned the work in Ghana, but we started this work because a number of refugees, doctors largely, started to write open letters in the press about a year and a half ago when the pandemic started to strike, to say that here they were, qualified people working in the UK, but unable to work either because of visa restrictions or because they didn't have experience in the NHS. And the NHS has a bit of a catch-22 situation where without experience you can't work in the NHS, or you're very unlikely to get selected at interview, but you can't get experience because you can't get in. So we looked at some of those barriers and working with some of the NGOs such as RefuAid and with the NHS Improvement in England colleagues, and have been able to get a number of refugees and displaced people and asylum seekers into jobs, nurses, doctors and allied health professions. And that would include the 160 Myanmar doctors, which Emma Mitchell spoke about earlier on today at this conference. And then we started to think, well, there's many qualified people in refugee camps across the world, and could we not start bringing them in to fill some of the vacancies, not as vulnerable and displaced people, but on professional visas, where they're competing with professional people from America or from the EU or Australia or wherever it may be. And we've started some pilots with in Syria and Lebanon with Talent Beyond Boundaries, an NGO that works with refugees who have skills, and conceptualizing them as displaced talent and bringing them in. And looking at the next slide, on the Northwest pilot, this pilot group, this pilot with Northwest NHS trusts, have taken nurses, for example, bringing them in to the NHS, giving them support for the areas that they need. And then at the end of the course, which is about 4 weeks, putting people into work, whether it's directly as nurses or as healthcare assistants, to give them more experience to build up that role. And then finally, we thought, well, there's many refugees, almost 1 million people, I believe, in camps who've got no opportunity of working and no opportunity of education. And why don't we start working with them and giving them the health skills like we're trying to do in Ghana? So finally, and to conclude with the final slide, I just wanted to say we remain fully committed to supporting the skills, qualifications, learning and experience of these precious international workers when they come to the NHS, to ensure that they have the right professional framework and conditions to operate at their best and to thrive and flourish in their career, whether it's for the long term or for the short term. And we wish to value them, and we want to get much better at this. So thank you very much. I'll end there. Thanks.
Thank you very much, Gail. So interesting to hear, especially about that work with refugees and of course, international recruitment, a hot topic and mentioned in the last session. So I'm sure there'll be some thoughts and questions on that afterwards. Thank you very much. I'm going to move on now to Tom Hughes. Tom is the Head of Global Partnerships at Health Education England, so leads on much of HEE's work on partnerships of various sorts. And without further ado, I'll hand on to him to tell you all about that. Thank you, Tom.
Thank you, Kit. If you bear with me, I'll attempt to make my technology work. So thanks and apologies for that slight delay there. As Kit said, my name's Tom Hughes and I'm the Head of Partnerships at Health Education England's Global Health Partnerships Directorate. I'm acutely aware I'm probably the least interesting person on this panel, so I'm going to really briefly talk you through what HE does in this space and why. How we see our work in global health partnerships work more broadly, sitting within the context of global Britain, and potentially some of the issues with global Britain as it's articulated at the moment. And I'll come back to how I think actually the partnership movement makes all of that soluble. As Gail's alluded to, I think it's a challenging time in terms of the SR. So I think it's worth being explicit about what some of those challenges in terms of the partnership movement might be. But Kit has specifically asked that we end on a hopeful note, so I will attempt to bring it back and end on a positive. But there was a turn of phrase at a talk I was at last week, which was, there are no safe spaces when you're trying to talk about something as complex as global health. What we need is brave spaces. So I'm hoping that in that spirit we can have an open discussion around the health partnership movement, its future inside global Britain. So NHS Health Education England, you can see our elevator pitch or strap line at the top. We're a key part of the NHS and we essentially focus on the education and training of the current and future health workforce for the NHS in England. Now we recognise, as the Prime Minister said, that actually the work we do domestically has an international angle. So as well as investing in postgraduate training for doctors and dentists in the UK, undergraduate clinical placements for nurses, we allocate a very small amount of our resource, about 0.02%, to global activity. Now that falls into three broad camps. The first is educational support for international health workers to help them come to the UK, meet the regulatory standards and thrive while they're here. And I think Gail's talked really movingly about some of the challenges that some individuals face in coming to the NHS. And I know some of you will have seen Mumtaz Patel talk on Friday morning about the work HE is doing on differential attainment, because even when doctors and other health professionals are here in recognised training programmes, they're still seeing differences in outcome, and we need to work to attempt to address that. The second is overseas fellowships, which I think is part of the reason we work so closely with Theta. While Theta's ODA-funded programs focus very much on the primary beneficiary being the partner health system in a lower middle income country, with a secondary benefit to the UK in terms of the staff developing while they're there, we look at it from the other end. So we fund fellowships, typically 3, 6 or 12 months, for NHS staff to go and work and learn alongside their peers internationally, becoming better leaders, clinicians and health workers for the NHS in the future, but also leaving a sustainable impact while they're there. And finally, we work on technical collaboration and consultancy, focused on education and training, but with a view to sharing the expertise the NHS has in this field with our partners overseas. So I should probably say I've been to this conference for the last 3 or 4 years, and I always really enjoy it. And so when Kit asked, could you do a panel, I instinctively just said yes, really keen to do that. And a week or so later, I looked and I saw it was Global Britain. And I thought, okay, it's a bit amorphous. So I did a bit of research about what Global Britain is, and I've put a paragraph here that I want to unpick a little bit now. This is an integrated review, and it starts really strong. Deeds, not words. That's a kind of, it's quite a radical statement. It's the suffragettes initially, but it's this: you'll know us by what we do rather than what we articulate. And that's quite brave in a government document. I like that. In the middle, we start to talk about enlightened self-interest. I think that's their framing it as what we do will always be in the interest of the British people, but if we take a planetary health lens, we would expect everything we do to be in the interest of the British people in some form. We would never act against our own interests. The bit that gets tricky for me at the bottom is this kind of a force for good in the world. And that's not because good and evil are kind of theological, and I have yet to see a policy document that says that we're the baddies. It's, I think, when we think about global health and health partnerships, I think we need to be mindful of where we've been. And I think it's quite tough to say the UK has been entirely good for the last 300 years and its impact internationally. Checkered on good on balance, potentially, but I think it's worth thinking about this broader context of the UK's history when we think about what a new and global Britain might be, because we have had a global Britain before, and it wasn't always a positive thing. And I think, although there's a drive in a document saying we're not going to look at words, I think it's instructive to think about how things are framed. So if you look at the words influence or partnership, it's mentioned much less frequently than the idea of power. And I think one of the things that is potentially problematic in the way we articulate global Britain is it feels quite transactional. And I think that's not actually how civil servants or the government construe it. I think we should accept this as a good faith document that people want to make the world a better place in the interest of British people, but also because it's the right thing to do. But I think we should be explicit about where we've come from before we decide where we're going. I think I'm on the side of angels making this analogy, even though it's potentially a difficult thing for a government employee to say. Our chief executive last month said that HE was moving to become an anti-racist organisation, which is hugely positive and welcome. It's a difficult thing for an organisation to recognise that it plays its part in some of the structural issues in the NHS. I think a logical extension of anti-racism is probably anti-colonialism. So I think HE is probably in this space. And Joan Dion there, I think, an interesting quote I saw researching something different. And I think it's just about acknowledging who we used to be, even if we want to be someone different now. However, if we accept the Global Britain, the integrated review in good faith, as a proposition that the UK wants to be a force for good in the world, then partnership is really how we should be approaching this in the global health space. On the left, you can see the Theta principles of partnership. And I think these are the words we would hope to see embedded in all of our global health work. I know FCDO have some similar principles that underpin their work. And I think here, I'm acutely aware I've used the word power here after having a pop at colleagues at FCDO for doing similar. So if we're thinking about influencing people through our partnerships, then the key thing that underpins that, I think, is trust. So how can the UK be trusted in this space to do good? I would suggest health workers are the best ambassadors the UK could have. The health partnership scheme has been really powerful in this space. You can see at the top here, doctors, overwhelmingly trusted. Gail, unfortunately, civil servants like you and I in the middle here towards the bottom, but ahead of government ministers. So some work for all of us to do in terms of earning trust. But I think if we want the UK to be trusted as a force for good, then we could do worse than have health professionals be our ambassadors. And I think the FCDO, the integrated review, talks about integrating our approach to development and diplomacy. And I think healthcare professionals should be front and centre of that effort. Gail's alluded to the fact that it's going to be a really challenging time for the next 3 years in the spending review. We've heard about the ODA reductions. I think the NHS is not going to be swimming in cash. And so I think we as advocates for this, and I know Gail will be having these discussions inside DH arguing for funding, what will people say about looking to more health partnership funding? They might say it's duplicative. Staff are just doing this in their own time. NGOs will do it. Trusts will fund it. They'll say there probably isn't enough money. We need to use money differently, that it's too complex to fund things this way, bringing in the NHS and broader partners. And they'll probably say this isn't the right time. You know, the waiting lists are too long and the NHS can't spare staff to work overseas when things are so bad in the UK. Now, I think all of this is soluble, as I'll come to. I'll end on a high note, but I think we need to accept these challenges are going to be made and accept they're probably, hopefully, being made in good faith. But I think there is a way through it. And the first is the promises we've made to the NHS workforce, the promises we've made to our partners overseas. And I think this comes down to solidarity, which is the heading for this entire conference. So if we want to meet the challenges of the SDGs, and we want to meet the challenges the NHS has laid out for itself to be the employer of choice, the NHS people promise, then I think a big part of that is enabling people to build the career and the institutional peer-to-peer links that will enable them to enjoy their role in the NHS, to feel their place in the broader system. The partnerships we're talking about that Gail's alluding to in other countries aren't just government-to-government MOUs. They're underpinned by institution-to-institution relationships, and more importantly, peer-to-peer relationships. And I think the challenge in the NHS People Promise, the challenge in the SDGs is huge, and the transformative change that will enable us to meet both comes from these peer-to-peer links that give people's jobs meaning. And that's where I think we will find a way through, where the NHS and the partnerships programs can meet in the middle, because I think there's benefits to both that are huge. And I think our role as policy wonks and funders is to create an environment which is amenable to individuals working to catalyse the changes that we need to see in a global healthcare system. Apologies, I may have run over there, but hopefully it was entertaining enough.
Thank you so much, Tom. Certainly entertaining enough. I think we're warming up now, and thank you for turning it into a brave space. I sort of saw the delegates come alive when you mentioned the important to mention precariousness of being a global Britain based on our former global reputation. So, and we're starting to have some chat and the odd question now. So do stay alive, everyone, and do post comments in the chat box and do post questions. There's so much to discuss here. I'm going to invite now Liz Grant to the stage. Liz is assistant principal at Edinburgh University and has very long-standing and many interests and expertise in global health. She is a doctor. She speaks here from an academic point of view, but she also has close links with a seat on the board of the Scotland's NHS Global Citizenship Programme. And one of the things I want to point out here is just, I'm not sure how visible it always is from overseas or even within the UK, that the UK NHS is in fact 4 really quite different systems under control of the UK government in England and the devolved administrations in the other 3 countries. So Liz, I'll hand over to you to bring us your own perspectives, hopefully tinged with some perspectives from Scotland. Thank you.
Thanks so much, Kit. And it's absolutely fascinating, I think, to be here today, to have this conversation. And Gail and Tom, you've raised so many issues. We haven't compared notes, but what I'm going to do is actually follow on from some of the things that both of you have spoken about. And then hopefully there'll be lots of chance for and time for conversation. But can I just sort of even bring us back a little bit? And Tom, you flagged this up, this idea of global Britain and the idea almost and global health and where we go. And I was reflecting as I was preparing for this on Nigel Crisp's sort of, almost, it's revolutionary work, turning the world upside down almost, 15 years ago. Because at that point, he was really trying to say, look, it's about interconnectedness and therefore it's about interdependency. Global health partnerships, it's not about a one-way traffic at all. There's cross-learning, there's opportunity to co-develop the future of health. And this interdependence is really changing the way that we can see health. And I want to take that idea and place it here where we're talking about global Britain and global health. Because, Tom, you've alluded to this, there's a major problem, absolutely major problem now in where we are in the UK in thinking about global health, but it's not just a problem that the UK has, it's a problem that the world has. And in a sense, it's been made so explicit. And we've heard this time and time again in each of the conversations and talks throughout these last 3 days, is that there's such inequity in the world. And that inequity is being so exposed in the global health space. And vaccines, the access to global vaccines is probably the sort of visual of an extraordinary inequity in people's decision-making, in people's use of resources, in people's money, in how we think about each other. And we have something that we can do, because in health partnerships and in global health, we've got a space to turn this around, because health, and Tom and Gail, you both reflected on this, health can be an extraordinary diplomacy. It can actually change the way that everything else is understood. So that's what I want to do. I want to think about Nigel's turning the world upside down and say, it's actually, we've got to go further now. We've got to turn it upside down and turn it inside out. Because health allows us to change the very meaning of global and where we're at. And I want to make 3 short points and then come to this sense that we've got the UK as 4 different NHSs functioning together, bringing together the health of the 4 countries within the United Kingdom. And I want to talk about Scotland's specific way of, I suppose, doing and being part of an international development community, and Scotland's part in global health and global citizenship. So health asks us not to be defined by boundaries and borders. So even at the very start, when we are using the term global Britain, I want to go beyond that, because what health does is say there's something much more connected. We're a shared humanity. We have something in common. And actually, that commonality we've seen, and the opportunities within health work together are really striking. We also know that we shouldn't be thinking now in a rich, poor, low income, high income country divisions, because something else is changing in the world. Also, the way that we have managed the pandemic is a real indication that we need to think differently. Because who has managed to be most effective in supporting their health workers and health and people during this pandemic? What lessons can we learn right across that can help us shape our global activities and global citizenships? So we've got a health teaching us to go across borders and boundaries. It gives us that space. I think Ben used that expression this morning. It gives us spaces to cross those borders. Health allows us to define a global commons. Because really, if we're thinking about the big agencies that we have in the world to work with, what are the global commons, the agencies that we share together? And it's the agency of health. Not health workers or health systems, but actually health itself. And therefore, how do we boost and build health? We do so by strengthening health workers, by strengthening the systems, but also recognizing that health, and this is what the pandemic showed us, but the climate crisis has shown us even more strongly, health is not just about human health. The health of people and the health of the planet are so interconnected, so related. We've got to move forward working together and thinking about these together and thinking about everything we do as having intended and unintended consequences and calling those out. So I think that's what health does for us. It allows us to, if we allow it, it allows us to re-articulate the space that we're in, because our future depends on understanding our relationship with nature. Nature owes us nothing, but we owe nature everything. So how as we think about health, can we move beyond that? And the third thing is health, I think, gives us a raison d'etre to be a global citizen. It's the marker of our common humanity. So being a global citizen rather than a a national citizen. I think recognizing the power of health to do that. And that's what I want to come to now as well. The responsibilities that are underpinned by being a global citizen, and therefore global Britain. Global Britain is global as a country among countries. What's really significant is being a global citizen in a country. And being a global citizen means connecting and understanding the power that we have together with citizens across the world to do something differently. So it's moving beyond the country interdependence for health outcomes, as was really discussed, I suppose, 15 years ago, to this renewed understanding of global health as an asset, part of a global commons, reframing the dependence that we have on systems and the way that systems interconnect, and about sharing. So as we think of that, I want to just give you a little taster of Scotland's Global Citizenship Programme, and then come back to some of the issues. And actually, the document that Robin Niblett prepared on Global Britain as a global broker, just to ask that final question: is that where we sit? And if it is, what are some of the values that would have to underpin this? Because Global Britain as a powerhouse of trying to do power is not what global citizenship is about. So global citizenship in the NHS Scotland understanding. So our model and our remit is very much one that's been developed over the last few years, thinking about what are the principles and what is the opportunity to work globally and to work locally, and to tie the global and the local together. We have an absolute commitment across a centralised global health coordination unit that begins to draw people together. We have a people register within the NHS for all of those interested in global citizenship. We have a champions network across each of our boards, our NHS boards, as they join together, and those champions try and encourage and facilitate people who want to engage in global partnerships. And we have an NHS programme advisory board as part of the Scottish Government and the Scottish Global Health Executive Committee. And why is that important? Because I think in our global NHS citizenship, global health citizenship, it's saying that we have a national policy direction that reflects where Scotland identifies the power of partnership, and the power not in a controlling way, but the opportunity in partnership that allows us to learn. It's something about recognising the values that each person has. It's something about understanding that our opportunities to work in partnership require education. They require sharing educational resources. They require learning from other countries, and that's facilitated in this NHS Global Partnership, and also through the resources that the partnership or the Global Citizenship Programme try to develop. And we've got things like our new Sustainable Development cards for every health board, and this sharing stories as well. And it's something also around ensuring that our global citizenship work isn't seen as sporadic volunteering. And I think that's what Theta, you have done so well. You have really showed that global citizenship is not sporadic volunteering. It's about commitment. Citizenship isn't something that people do in their spare time. Citizenship is what we are. And therefore, believing that actually changes the way we work together. And it means, as both Robin and Gail has spoken about, there has to be trust together as we work together. It's about understanding we're interconnected, that our decisions, our practice here in our NHS boards on a day-to-day level actually matters, and that influences citizenship elsewhere. It influences how we see ourselves. So how do we share practices around better management of waste? How do we share practices that are about sustainability? How do we learn and incorporate those into all our practices? And it's about that recognizing that as we strive for human health and wellness, we're striving for this healthy planet. And as we take all of that together in this sort of the global citizenship work, and recognise that the different partnerships across in Scotland, and we have through our international development strategy a refreshed partnership agreement that works with for specific countries. We work with Rwanda, Malawi and Zambia as specific countries with the International Development Division, and also with Pakistan. But alongside that, our global citizenship actually recognises that people have choice and have built up partnerships across the years. And those partnerships with so many different countries and so many different organisations actually matter as well. So in conclusion, because I'm conscious my time has gone as well, I just want to draw us back to what I said about global Britain and Robin Niblett's comment about being a global broker, because Robin actually talked about what are the values underpinning global brokership, if that's a role that the UK take. And the values have to be those that we've talked about around care and compassion, around equality, around understanding that decisions have to be made together, around trust, around seeing that the local and the global connect, around the extraordinary opportunity of health as calling out that we go beyond boundaries and borders. The values also have to be worked out. Robin Niblett has finished his comment, this paper with a statement, and I think it's really important because you've reflected on it earlier. The world needs less talk and more action. In this sense, a role for Britain as a valued and creative global broker must be earned, not declared. It'll emerge only from the competence of UK's diplomacy, from the impact of international presence, from trust in its word, and from a return to the power of understatement from which the countries was so widely respected. And there's something in that I want to say that as we think about and conclude around global, what really determines and defines our global, our sense of global Britain. Can I turn it on its head and say, what defines our sense as a global citizen? And if defining our sense as a global citizen really brings us together to recognise the global commons, to work together, then we can move forward. If it doesn't, then, and the actions don't from governments with the cuts, etc., then there is a real call as to what we're talking about. I'll stop there, and I know we'll continue on the conversation. Thank you.
Thank you so much, Liz, for no slides and I think no notes, and yet an incredibly insightful and thoughtful talk, and so much for us all to think about there, I think. I should point out that I think, so Liz mentioned the International Development Strategy, talking about Scotland's International Development Strategy, because Scotland is unusual amongst the devolved nations in having its own ability to spend official development assistance, which Northern Ireland and Wales are not able to do, and therefore has its own strategy. So just to point that out. Of course, lots there about interconnectedness and moving beyond borders, which I think perfectly brings us on to our final speaker, who is Perpetual Oforiampofo, who is a nurse and a nurse educator. She is the president of the Ghana Nurses and Midwives Association, with a long history in trade unionism, and amongst many other positions and accolades, founding fellow of the Ghana Nursing and Midwives College. So I will pass on to you, Perpetual, to give us your thoughts on the UK's approach from a partner country. Thank you.
Thank you so much, Kate, and greetings to everyone. I bring you warm greetings from Ghana and from the Nurses and Midwives of the Ghana Registered Nurses and Midwives Association. You know, it's very good you kept me as the last speaker. I've had to actually absorb a lot. And I'm really thankful for that. And I want to express my gratitude to TED for this invitation, especially to you, Kit, to be a panelist. And I want to commend the organization for all the efforts you are making at creating the right environment for global health by educating and training health workers in Africa and Asia through partnerships with organizations and volunteers. And you've been doing this since 1988. Kudos to you. So I've been asked to bring on board some experiences and priorities for UK global health engagement from a lower middle income country like Ghana. So I'll speak a bit on this, and then if there's still time, maybe I'll touch on some of the things that or issues raised by the other panelists. So UK, as we all know, has benefited from health workers from many developing countries in the past and in current times, including Ghana, and is now Ghana now classified as a lower middle income country. Let me start by saying I completed my nursing training in 1999, and at the time we were about 90 graduating nurses, and within 1999 and 2000, all of my mates had moved to the UK, and just about 20 of us were in Ghana. So the point is, since then and before then, UK had benefited from Ghana in so many ways in terms of the movement of health workers into the UK, including nurses and midwives. And the migration of these health workers is their right. Nobody can curtail them where they choose to go. But we all know that it is no fault of UK having attractive work environments that attracts them, and then also serving as the pull factors. And back home in our countries, the kind of push factors that are in existence that motivate people to also move. But regardless of the push and pull factors, migration of healthcare workers from developing countries to or lower middle income countries to more developed countries like the UK and the Americas has actually done more harm than good on the healthcare systems of our destination countries or source countries. And the well-being of any population and its productivity are linked. And therefore, migration of healthcare workers directly affects any nation's productivity. The key losses include the loss of skilled professionals, loss of investment from education and training over years in terms of these personnel, and reduced fiscal income to the country, which leaves much to be desired. I must say that more recently, in recent times, the UK is developing partnership with Ghana to recruit nurses and midwives to the UK through bilateral agreements between the two countries, which will actually formalize the recruitment process. But the question is, how will this partnership become mutually beneficial to Ghana and the UK? It shouldn't be one-sided. And therefore, policy and agreements must not only remain on paper, but must also be translated into what is implemented. And I think it borders around the issue of trust that Tom mentioned earlier. Let me say that as at June 2011, the Ghana Registered Nurses and Midwives Association, in partnership with the Public Services International and other health affiliates of PSI, actually conducted a study in Ghana, and it showed that between 2002 and 2005, 71% of all nurses and midwives who left Ghana headed straight for the UK, and the rest for the USA. And in fact, current trends are showing that nurses and midwives are still moving to the UK, the Europes in general, and to the Americas. No particular studies have been conducted within this period, meaning 2020, 2021. But there's no doubt that there's a high need for nurses and midwives within the Europes and Americas and elsewhere with developed countries. And therefore, for countries such as Ghana, there is the potential, very high potential for people or health workers to move. And that is what we are seeing with our nurses and midwives. And it is, what I'm saying is based on the fact that many of them are putting in applications for study leave without pay. If you put in an application for study leave without pay, it means that you are leaving and you don't intend to come back anytime soon. So the largest employing agency in Ghana, which is the Ghana Health Service, is in fact receiving a lot of these applications. And I remember as of last Friday when a discussion, I raised it, the ministry, although it's aware, was not endorsing what I was saying, but the Ghana Health Service came in to say that yes, indeed, the Human Resource Department was receiving a lot of these applications, and it only gives a signal that these professionals are moving elsewhere, or they intend to move elsewhere, or they are preparing to move elsewhere. So we need to get to a level where partnerships can be mutually beneficial for governments and societies at large. And the policies must reflect the relationship between migration and development, and most importantly, the development of the health worker. The UK must begin to look at the various phases of producing a health worker. And when I say this, I mean producing a health worker within a lower middle income country or a developing country, because it all borders on investments. The UK must be looking at also investing for future gains. So when you look at these phases, we are looking at the period of training, looking at the period of internship, placement, work, career progression, in terms of getting on fellowship or specialist training up until retirement. And then, of course, the bigger picture of also faculty. So it's important that the UK begins to look at these as directions for partnership, and not only as looking at the issue of just recruiting. And that is why I want to say that the UK can actually assist these source countries, including my country, Ghana, to improve the training infrastructure and develop new ones with focus on faculty. And that will adequately help to prepare these persons who go through the training for future work. And we must also, in these processes, involve worker organizations. Specifically, I'm talking about the unions that represent these workers or these health personnel. And the UK can also get involved in terms of the training and the curriculum, the caliber of workforce that we need to actually churn out yearly. And let me say that for nursing and midwifery in Ghana, at the moment, we have undertrained the professionals. So we have overtrained the auxiliaries, and those are the certificate holders, and those who hold the diploma and degree are rather undertrained. And we know that this does not impact positively on quality healthcare, and that is for patients. And therefore, we need to move away from these auxiliary trainings and focus more on the degree in the long term, but in the short term, see how we can gradually probably phase out the diploma as well, because research has consistently shown that patients are safest in the hands of highly skilled professionals who by academic standards are those who have attained more knowledge within their professions to be better able to understand the conditions they are dealing with, make critical decisions on the part of the patient on their toes. And this is the issue about the involvement of the UK in terms of the training. We must also consider the UK looking at partnerships that can also inform the numbers that are trained, because what we are seeing in Ghana now is the fact that, okay, we can actually train for export. Already we've gone into bilateral agreement with the Barbados government, and we've moved some nurses there. And there's more coming in terms of moving more nurses from Ghana to Barbados. We are informed that a lot of arrangement is also being done with the UK to move some nurses and midwives to the UK. But we must look at the issues of numbers. It is very wrong to continuously train people without getting them employed. And I think this was mentioned by Gail earlier on. The unemployed that are all around in these countries, she mentioned Kenya, and we have same in Ghana, she mentioned 40,000. But I can bet you that the 40,000 is made up of more of the auxiliaries than the professionals. So in terms of numbers, we should be looking at how we can adequately train the numbers to serve home purpose and also move them elsewhere to practice. And we must look at the improvement of health facilities in lower to middle income countries and developing countries to be better prepared to impact positively the training and the acquisition of the quality skills that makes a health worker marketable for any country. And the UK must further partner source countries in terms of developing the requisite conditions to attract and retain workers in their own countries. And Gail mentioned the rural incentive package. I am part of that technical committee, but I must say we are still at the beginning points of developing. The WHO is in, and the consultant has finished the next review. They are going to move to the field to gather data that will inform what the package should be. But I will ask Gail later to inform me, because I need to know how far the investment or the support has been in this direction. If there's any money indeed that is going to top up their salaries from the direction of this UK partnership. And the June 2011 report I mentioned earlier showed that nurses and midwives were ready to actually stay in Ghana and work whilst they have their families there with them, if they had decent living wages, if they had accommodation they could call home, if they had medical care for themselves and for their dependents, if they had the equipment and logistics to work with, if they had improved work environments that were safe and everything good that comes with it. And therefore, the governments, Ghana government, UK governments, must begin to sit up and to do the needful. There's the need to retain health workers. And if the policy is to now also export to other nations, then we must look at the whole concept holistically so that it will be beneficial to all countries in terms of partnerships that we create. And let us remember that we all have 2030 as a target to achieve the sustainable development goals, especially in the context of health, the health-related goals, and to achieve universal health coverage. So whatever it is that we are doing must impact all countries positively. We never know when another pandemic might hit, and we have all seen the challenges that we've had to bear, even in terms of more developed countries. And it's about having partnerships that will impact positively on all nations, including the health workers themselves. Thank you so much for the opportunity.
Thank you very much, Perpetual, for that perspective from where you are, and it clearly has been rousing our listeners. There have been hearts and claps and likes going up all over the place, so you have clearly hit a nerve with many people with what you've said there. Time is absolutely flying here. It's we've got 13 minutes left of this session. I can hardly believe it. I have so enjoyed listening to you all, and the themes coming through as for the whole conference of the need for solidarity, the need to be connected with each other, the levels at which that happens, so through governments, through institutions, and peer-to-peer, I think the peer-to-peer has come through today as well, and the crucial need for trust. And that coming through, I think, from Perpetual's talk, that perhaps the trust is not always there, but hopefully we can build that. And I had initially suggested that I would come back to speakers to respond to each other, but I think we need to turn to the delegates now. And I think there are lots of questions, and I think they will help you respond to each other in a sense. And I'm going to go first to the very first question, in fact, from Evelyn Brealey. And I don't know if perhaps Daniela could put this up on screen, but just are we, and this ties in very well with what Perpetual was saying, are we really ensuring the ethics of international recruitment? The NHS is largely recruiting from areas where the ratios of patient to healthcare workers are much worse than in the UK, and are we in danger of ethics washing with some of the initiatives presented here? And I'm going to link that actually to one at the top from, I'm sorry, I won't pronounce your name properly, Shuta Gidwani, and link to that, how can we make reciprocity more real? I'm going to put that first, inevitably, to Gail, but others may want to come in and answer that. Gail, would you like to respond to that question and part of the second question?
Yeah, sure. So we want to make sure that our international recruitment is ethical. It's happening anyway. We divide it up into passive recruitment and active recruitment. So passive recruitment is when people bring themselves, and that's a huge thing with doctors. We have massive numbers of doctors, mainly from India, Pakistan, Sudan, Egypt. These are all countries which send a huge amount of doctors that they bring themselves. They're highly mobile people who find their own way to come to the UK to work. With nurses, it's a little bit different. So nurses are largely recruited from the Philippines and India, but there are new markets now coming on stream from across Asia, but also more and more with Africa. And I think Africa has got that the demographic of a very young population, that means that all countries are going to be looking at Africa for healthcare workers in the future. So getting this right in a way that isn't depleting Africa of its valuable workers is really important. So we, the UK, have held an ethical recruitment framework since 2004. We've recently republished it this year. It aligns with the WHO framework, which was also updated this year, but was produced in 2010. And that framework has 47 countries that you cannot recruit from because of concerns about healthcare worker ratios to universal healthcare coverage. That's not to say that if those countries wanted to have a relationship, so Ghana's on that list, that they couldn't, but it would have to be really managed and really carefully done. So our thinking is, how can we allow people to come and work in the UK if that's what they want to do, but in a way that doesn't deplete their country of workers. So the Philippines model is quite an interesting one. The Philippines and India, actually, India wants to be the supplier of healthcare workers to the world in the future. They train excess supply of workers. They're giving people a job. It's increasing education into remote and rural locations for nurses, particularly for girls, because people want to get a job and the opportunity to migrate. Although actually the majority don't migrate, they stay at home, so it increases the numbers generally. And then people receive the remittances, which the evidence would show are pro-poor, so the money that they send back to their countries, and it's reducing unemployment rates. So that's the sort of general model. Also, recruitment companies have to pay a fee for it when they do active recruitment, and there's all sorts of ways that fee could be useful. So the Philippines push it back into nurse training to train more nurses, but in African countries, for example, it could be used for more training. It could be used for salaries. So 2 nurses come to the UK, say out of that 40,000 unemployment pool in Ghana, and that would pay for for a nurse to be back in work in Ghana, for example. So it's about how can we innovatively do this. I totally agree as well about the training, and hence my department we've received 5 million for this this financial year to invest in training, and we've done that in partnership with Theta to do things like rewrite the curriculums, support more training to help HR, health HR, policy and management, so that the unemployed nurses can get back into work in some way. It's a drop in the ocean. I'm the first to admit that, and we need to do much more of that. And I think countries that import more health workers than they export, perhaps ought to there ought to be much more thought put out about how they pay for those the training and the education of those healthcare workers. I totally understand that, and I think we certainly in the Department of Health and Social Care want to do this in the most ethical way, sustainable way. What is quite interesting in the evidence is certainly from countries like the Philippines, it shows that for every nurse that goes, there's a recent study that came out last year, shows that every nurse that goes to the Philippines, to the US, 10 other nurses are registered in the Philippines. It's really the incentive of an international job does draw people into the sector, and then it's important that the sector is able to train up people to the levels necessary to stay in their home countries. I've also been quite interested in how countries attract their workers back, and there's not an awful lot of information about this, but Cuba does it. So Cuba gives a flat and a car to doctors that go back to Cuba after an international career, and Thailand has invested really heavily in health tourism. So when people come back from working in the States or in Europe, they go back into hospitals which they feel that they can operate in, because it's very different skills that you need to run a 50-bed hospital, say in Malawi, to working in a modern health system in America, for example. So it's about so in Thailand they're looking at health tourism, and I know that Ghana is also interested in the long term looking at health tourism in the west of Africa. So let me leave that there. There's lots of things that I haven't that I've left unsaid, or lots of areas to follow up on, but I just really want to assure people that it is really important to do this really properly and ethically in the interest of the worker and the health system of the supply country. Thanks.
Thank you, Gail. And I wonder if any of the other panelists want to come in as much as anything on the reciprocity aspect, and if you have any thoughts on how we manage that better and more strongly. Tom.
Health Education England thankfully stays away from terms and conditions, and I'll nod to Gail, who carries that torch for us. But I really like the idea of, if you recruit a nurse, you have to give a day's paid leave to someone to do something global in your patch. I don't know how it works in Scotland, Liz, but the idea of citizenship for organisations feels really interesting, whether you could start to encourage that type of behaviour. But I wonder that we don't do enough in this space. Gail's outlined some things that we're doing that are a great start, but as you say, are a drop in the ocean. And however much, we have our fingers crossed for you, Gail, hundreds of millions of pounds of ODA with a little luck for DH in this space, but it's going to be the peer-to-peer and individual and institutional links that really drive a lot of this, and that kind of mainstreaming of the idea of, we've got something, it's part of a broader partnership, we should be giving something back. Query what? I like the idea of a day, and I'm going to leave that one with Gail to get in the agenda for change contracts next year. But I think there's something there, not just for governments to own, but institutions, although governments have to give them that framework, and someone has to pay eventually, and query who. I think it's going to be a challenging few years, but there's more we can do in this space, and we should.
Thank you, Tom. Liz, I think, is going to come in as well.
Just to echo that, I think that's so important. And coming back to the citizen piece, because reciprocity, we have to watch in reciprocity that we still don't get into an us and them mentality. I think the real gift of what we have here and what health partnerships can do is to broaden out and show that the reciprocity and the paying it forward and the being part of a community together can mean that someone working in health can also be working with somebody in education, somebody in transport, beginning to see that all of these things connect. So therefore, that part of the partnership care is actually working out where opportunities to feel that we're together making the world a better place, and it's not just in one small system. And picking then Tom's point, individuals can make an enormous difference, but really we need organisations and institutions and the NHS, and that's where I think NHS is taking up the mantle, but it needs to take it up more to actually become a sustainable NHS that recognises not just what it's doing within its own footprint, what it's doing globally, but how we can share together and ensure that we're not being destructive on the one hand while opening our hands out in the other.
Thank you all. I have permission to run over time, but I feel that's probably a little unfair on both speakers and listeners, so I'm not going to. What I'm going to do is just return to Perpetual for a moment, because I feel that the last conversation was kicked off by your talk and questions along those lines, to see if you want to respond to what's been said, and then with apologies, I don't think we'll be able to answer any more questions. But Perpetual, would you like to add anything to the conversation?
Well, not much, but to say that it's been an interesting discussion, and I understand the hot seat that Gail sits on, but in fact, there is need for health workers everywhere, whether they are moving passively or actively. There is still the need in this futuristic idea of having innovative ways of having healthcare workers move and work in other places, but to ensure sustenance of the health systems that these source countries have, because that's the only way that we can help build those societies and have healthy populations for the future. Thank you.
Perfect. Thank you so much. I feel that I should make some Perpetual, 2 minutes, please. Thank you. I feel that I should be making some terribly insightful, chairish comments to wrap all this up, but I think you all panelists have done it along with the chat and the question and answers there. So I'm simply going to say thank you very much for such a fantastic discussion. We started with challenges. It's clearly a challenging area, and I hope we will all continue to work on this as the next months and years go by. Thank you.